Hello, I am Martin Lederman, co-founder of the organization One World, One Vision. Over a decade ago, my associate and I, while on a surgical mission to Belize, founded One World, One Vision in order to train local ophthalmologists and, by doing this, extend our reach. We were successful, and since then, our organization has gone to multiple countries and have demonstrated the success of our ideas. We added anesthesiologists and pediatric intensivists to the mission in order to train local physicians and make the surgical experience of our patients safer. Since then, we have realized that the paradigm of one patient, one student, and one surgeon, while successful, could not begin to address the need. There are tens of millions of children and adults with strabismus and amblyopia. We decided, therefore, to support and to promote a video course in strabismus and amblyopia and approached Dr. Burt Kushner to develop a curriculum and to recruit worldwide experts to give lectures. We stipulated that the course should be translated into multiple languages and to be distributed without cost around the world to eye surgeons. We are particularly grateful to our former patients and friends who have given the financial support to make our dream a reality. We are delighted that Dr. Kushner has accepted the challenge, and we hope you find the lectures both stimulating and educational, and that you share them with your colleagues and your students. And so, without further ado, I give you Dr. Burt Kushner.
Welcome to this One World, One Vision comprehensive course on strabismus and today's lecture on the sensorimotor exam. If you're new to this series, I'm glad you're here, and if you're a repeat viewer, I'm equally happy to welcome you back. And I'm delighted to introduce today's speaker, Professor Carol Arnoldi. Professor Arnoldi is an assistant professor at the University of Buffalo. She's the program director of the Ross Eye Institute Orthoptic Fellowship. She's published 49 peer-reviewed papers, 10 either textbooks or chapters in textbooks, and she's co-editor-in-chief of the Journal of Binocular Vision and Ocular Motility. It's with great pleasure that I turn this over to Professor Kyle Arnoldi.
Thank you, Dr. Kushner. The prevalence of strabismus has been reported from 2 to 5.6% in otherwise normal healthy children and up to 2% of adults. 1 in 25 adults will develop strabismus during their lifetime. The first step in any comprehensive course on strabismus is a review of the sensorimotor exam, where we gather our data and interpret our results. This is what I will be presenting to you today. In addition to all the new patients with strabismus, patients scheduled for strabismus surgery, and all postoperative strabismus cases, there are several other groups of patients that benefit from the sensorimotor exam. These include patients with binocular vision complaints, even if they do not appear to have strabismus. Also, adults with a history of childhood onset strabismus or amblyopia, but particularly if those adults are scheduled for refractive or orbital surgery. And finally, any patient who has an increased risk of strabismus due to their medical or ocular history. The purpose of the sensorimotor exam is to efficiently and accurately gather the essential patient data. Now, this will include clarification of the patient's symptoms, patient's needs, and expectations. Of course, we're going to assess eye alignment and ocular motility, the static and dynamic components of the motor part of the exam. We're going to evaluate the current sensory state and determine the potential for binocular vision to aid in the diagnosis and formulation of a plan. Now, in practice, the exam does not necessarily follow a nice, neat path, because each point of data that we collect from the exam has the potential to alter our course, We often have to double back or take a detour depending on the discoveries we make during the exam. So where does this roadmap begin? Those of you who have studied physics are familiar with something called the observer effect. This describes the changes in a phenomena that occur simply by the act of observing that phenomena. It occurs because the instruments or the methods that we need alter the state of what they are measuring. Now, the observer effect doesn't just apply to particle physics. It also applies in medicine and strabismology. But we don't call it the observer effect. We call it exam dissociation. With exam dissociation in mind, some clinicians feel very strongly that sensory testing should be done prior to any other exam component, with the exception of the history. They argue, in spite of published evidence to the contrary, that even testing vision has the potential to irretrievably break fusion, dissociate the eyes, and destroy any trace evidence of a fragile binocularity. Specifically, many clinicians prefer to start the sensorimotor exam by testing stereopsis. But by doing so, many patients who could not possibly have stereopsis due to their strabismus or perhaps decreased vision are being repeatedly exposed to the test, giving them an opportunity to learn the correct answers. Eventually, that test may become meaningless. And by doing the sensory evaluation first, the examiner works in an open loop framework, without input or feedback from the exam to guide clinical judgment. So, to avoid inadvertently omitting some critical sensory test, one is forced to perform every version of every test, and that's simply not efficient. I almost always begin my sensorimotor exam by testing vision. Vision is always our priority, regardless of our subspecialty in ophthalmology. Beginning here also maximizes exam efficiency, which is critical when working with children in particular. How does it improve efficiency? Well, in the adult patient, it allows us to immediately detect distortion, monocular diplopia, anisoconia. These phenomena can impact fusion potential and can also be confusing if you don't know that they are present when you begin your sensory testing. But more importantly, knowing the visual acuity will help us to choose the appropriate motor and sensory test to complete on the exam. And in the child, because amblyopia treatment is time sensitive, we need to maximize cooperation and attention span, get an accurate vision before anything else. Now, this is not a lecture on vision testing per se, but it would be valuable to take just a few minutes to review testing vision in the nonverbal or preverbal child. Children as young as age 2 can often perform optotype testing, particularly with a pointing and matching response. If we really need to quantify acuity at this age, there are some tests available based on minimum visible visual function. These are the OKN drum, the forced choice preferential looking with teller acuity cards, the VEP, and other such tests. But these tests typically overestimate acuity, and they're not always reliable in detecting mild to moderate decreased vision due to strabismic amblyopia. So it may not be practical or even necessary to use these methods routinely. Instead, testing vision in the preverbal patient is usually qualitative, using ocular motor responses to visual stimuli. Because the most common cause of decreased vision in young children is amblyopia, and amblyopia is almost always unilateral, we can detect it by determining if the infant has a preferred eye. We do this using a 3-step process. The first 2 steps are done with one eye of the patient occluded. The examiner will be able to evaluate the quality of monocular fixation and compare the result with the other eye. But the 3rd step is arguably the most important. Here, we are giving the child a choice as to which eye they would prefer to use. This allows us to detect a fixation preference in the presence of an amblyogenic risk factor such as strabismus. And that's usually enough to make a qualitative judgment of visual acuity and to make a diagnosis of amblyopia. In a child with visible strabismus, this is easy. Child fixates with the right eye, we force occlusion with the non-fixing eye, and then we will take away our occlusion to see what happens when the child is given the choice and can use either eye. Do they continue to fixate with the eye that we forced fixation, or will they return to their previously fixating eye? In the child with straight eyes, this is going to be more difficult to do, straight or nearly straight eyes. Therefore, what we're going to do is add a prism in the induced tropia test to create a vertical strabismus and then see how the child responds. Remember that the induced tropia test is only necessary for those patients with straight or nearly straight eyes. Any child who does not have a strabismus that is easily visible to the examiner. The addition of the prism is going to create diplopia, forcing the child to view with the clearer eye for fixation. I find it helpful to introduce the prism and then occlude the fellow eye. I'm forcing fixation with the eye behind the prism to see what that looks like to me. It is important to use a moderate-sized prism with the base held vertically. You don't want a prism too small because you will not be able to see which eye is being preferred. And a prism that is too large is going to blur the eye behind the prism and may mask or accentuate a decrease in vision. One also must repeat the test with the prism over the other eye. This is all about symmetry, so we must be able to compare the response of the right and left eyes. You can also do the induced tropia test with base-to-base prism held over the child's eyes simultaneously. There are advantages to using this method. Using two prisms of equal value means that they will be equally clear. So we won't be preferentially blurring one eye over the other. I think it gives us a more accurate idea of which eye is being preferred. Since we are simply looking for an asymmetry in fixation behavior, we can even use higher powered prisms in this case, as long as the power is the same over each eye. By holding it base to base, we are creating an esotropia, and we can easily view the fixation preference. All right, so we have our visual acuity. What is the next step? In my sensorimotor exam, that step is eye alignment in primary position at distance and near. As previously mentioned, not all clinicians like to look at alignment before sensory testing, but for me, this step is critical in my choice of sensory tests. For this step, I have two objectives. Number one, is there aphoria or tropia, or an intermittent deviation, or a tropia superimposed on aphoria? And two, what is the size of the tropic angle? Is it small, medium, or large? The answers to those questions will determine how to proceed with sensory testing. What type of binocular vision do we need to test, in what order, and using which test, as well as how to interpret those responses. There are several different methods that you can use to detect and quantify an eye misalignment. They tend to fall into three main categories. The first that I will speak about is the corneal light reflex tests. They can only detect atropia and tend to significantly underestimate the deviation. Their accuracy relies on the ability of the examiner to detect a millimeter or less displacement of the corneal light reflex. And this is why these tests are particularly inaccurate for smaller deviations. They also do not control for accommodation, which may significantly influence eye alignment, especially in children. But for the very young or uncooperative patient, and for those with poor vision, this may be the best test. The next group are the diplopia tests. These include the Lancaster red-green, the single Maddox rod test, Hess charts, and others. Just like the light reflex tests, though, these tests do not control for fusion, so they cannot distinguish between aphoria and atropia. They also do not control for accommodation, so responses may be variable. They cannot be used accurately in those with abnormal binocular correspondence, and of course, special equipment and expertise is needed. The favorite tests are the cover tests. We use the cover tests whenever possible. The patient must have foveal fixation for these to be accurate, and they are best used in older children and adults, but you can even use these on very young children and infants. The cover tests are considered the gold standard. Why are they considered the gold standard? It comes down to precision and accuracy. They are the most dissociating of the three types of tests, so you're more likely to uncover the full deviation. They are the least subjective of the three types of tests. They control for the effects of accommodation, which the others do not. They are easier for the examiner to determine the endpoint, at least in my experience they are, because it's easier to detect a very small refixation saccade than symmetry of corneal light reflexes. And they can differentiate between aphoria and atropia while quantifying both. The cover tests are the gold standard, but only when they are performed correctly. So let's go through some notes on technique. Number 1, use appropriate occlusion. The method of occlusion must obstruct the peripheral field. This is because it is peripheral retinal input that tends to drive fusion more so than foveal input. So if you want to fully dissociate the patient, you need a good occluder. If you must use your hand, use the palm. Don't ever use your thumb. The thumb is good for blocking the fovea. You could occlude the fovea and check vision that way. But I wouldn't recommend it. But this will not block the peripheral input. Next, once you've introduced the occluder, allow time for the patient to fixate with the uncovered eye. I actually count to myself quietly as I'm holding the occluder over the eye to make sure there is enough time. So pause and observe for 1 to 3 seconds after introducing the occlusion. Now, those patients who have decreased vision or visual field defects, you may need to pause for a longer time, allowing the patient to take up fixation with that eye. Then transfer the occluder very quickly across the bridge of the nose to cover the fellow eye. We do it this way because we must simulate uninterrupted monocular fixation and never allow a binocular view at any time. Next, place the prism over the deviating eye, even if that eye has worse vision or is the involved eye. At this stage, we want the patient to fixate as is their habit. Our goal is to quantify the deviation that the patient most likely demonstrates most of the time, because this is the deviation that will be manifest during our sensory testing. So we need this number to be able to interpret our sensory test results. So initially, prism placement is guided by fixation preference, although later in the sensorimotor exam, that will change. The next point is to be careful to keep the prism in the frontal plane. I say this assuming that we are all using plastic prisms. That is the norm currently. And plastic prisms are calibrated for the position of minimum deviation, which is approximated by the frontal plane. If one is not careful, the prism may inadvertently be rotated slightly around the horizontal, vertical, or even anterior-posterior axis during your measurement, and this will lead to gross inaccuracies in your measurement. In this illustration here, you see the prism can be easily, accidentally rotated, in this case around the vertical axis, and is going to change the effective power of the prism. I also measure to reversal, not to what I perceive as no shift, meaning I can no longer see a refixation saccade. I go further than that to make sure that that was the true endpoint. Small shifts in fixation can be difficult to detect, especially if your patient has other issues such as saccadic intrusions or nystagmus, or the patient is very young and curious and looking around the room. Reversal of the deviation using this method will ensure that your endpoint is accurate. Take your time with your alternate cover test. Make several passes with the occluder to make sure that you got all the deviation measured. And finally, periodically ask the patient if the target, the fixation target, is still visible. They don't always tell you that the target is now obstructed by their nose, by you. So do remind them that they need to fixate on that target at all times. The simultaneous prism and cover test is another type of cover test that we use under special circumstances. It is used solely to quantify atropia. Now, it can be used in any patient with atropia of any amount as an alternative to the prism and alternate cover, but we don't usually use it that way. It is typically reserved for those cases where the cover-on-cover test and the prism and alternate cover test yield vastly different results. This is because the simultaneous prism and cover is more difficult for the examiner to identify the endpoint. We are watching for very small refixation saccades behind a prism that is blurring our vision, our view of the patient's eye. It is critical that you introduce the prism and the occluder simultaneously, as the name of the test suggests. Do not place the prism over the deviating eye and follow that with a cover-uncover test of the fixing eye. This is because adding that prism without the cover will trigger fusional vergences in those patients who have that ability, and you will end up overestimating your deviation. So the cover tests include cover-on-cover, simultaneous prism and cover, and prism and alternate cover. If we go back to our sensorimotor roadmap, we see that because our first objective is to determine if there is a manifest deviation, we will use the cover-on-cover test. We will follow that with either the simultaneous prism and cover or the prism and alternate cover to measure the full deviation. Cover tests are typically used in combination and often in the following order. First, we set the fixation target, an optotype that is 1 to 2 lines larger than the threshold of visual acuity in the worst eye. Yet another reason to test vision first. From there, we're going to look at the cover-on-cover test to see if we can detect atropia. At this point, we could go one of two ways. We may go straight to a simultaneous prism and cover if the angle we saw during step 2 was small. Or we may go directly to the prism and alternate cover test. There are even cases where we go all the way through to the prism and alternate cover and have to backtrack then and now do the simultaneous prism and cover test. We now have visual acuity, and we now know whether the deviation is small, 10 prism diopters or less, medium between 10 and maybe 30, or large, something larger than 30 prism diopters. If our plan is to evaluate binocular vision using tests in the order from least to most dissociating, we would begin our sensory exam by quantifying fusional vergences. In my experience, motor fusion is the most overlooked and underrated component of the binocular vision exam. But I think it's probably the most important. I think this is because it is often assumed that those patients with a manifest strabismus do not have motor fusion, when that's not always the case. Sometimes the patient just simply does not have enough fusional vergence amplitudes to control the deviation if it's moderate or large. In other cases, the patient has anomalous fusion with a pseudofovea. This would be more the case for a smaller deviation. In still other cases, the patient has suppression that is preventing the recruitment of fusional vergence, even though their fusional vergence is quite robust. I think clinicians also tend to assume that those patients with dense amblyopia or reduced vision in one or both eyes don't have motor fusion either. But as I mentioned earlier, peripheral retinal input is a far stronger stimulus to fusional vergence than is foveal input. It is definitely possible to have fusion amplitudes in these cases. So I would argue that motor fusion is the most important and valuable type of binocular vision, certainly for the patient, but also for the surgeon. Motor fusion is what keeps the eyes aligned. Testing motor fusion will reveal a target angle range and margin of error for surgery. It can estimate the ability of the patient to respond to moderate post-operative drift over time, and it can be used as an objective, quantifiable measure of control over an intermittent deviation to assist in determining the timing of surgery. This step, motor fusion testing, may be skipped if you have a large angle constant deviation and in those with significant visual field loss. These patients may have motor fusion, but it's probably minimal and it wouldn't be critical to detect it. In multiplanar deviations, the way I do this is to offset the vertical and then measure horizontal amplitudes, or vice versa. To do this, we have the patient fixate on an accommodative target binocularly. So the accommodative target, again, is the optotype size that is 1 or 2 lines larger than the visual threshold of the worst eye. We'll do this at the appropriate testing distance, sometimes near, sometimes distant, sometimes both. And we can use the prism bar, a rotary prism, or a haploscopic device. There are many options. Personally, I prefer the prism bar for several reasons. It's portable, readily available. I don't need a power source. The patient's eyes are easily visible to me through the bar, and that is critical for my method of determining the fusion break. It's also really easy to use. There are disadvantages. First, you can get a false response if you rely solely on the patient's report of diplopia when they break fusion. These prism bars can blur vision, and some patients will interpret that blur as diplopia. Others will actually experience monocular diplopia and will report a diplopia point, a break point, when they are still fusing. The prism bar is going to be less precise in the higher ranges due to the larger jump in prism power at the end of the bar. And finally, these larger prisms will blur vision, which can artificially reduce the measurement that you're taking of the breakpoint. To quantify the range of motor fusion, if you have a patient going to surgery, if the patient happens to have a manifest deviation present, the way to do this is to offset the deviation first and then introduce the prism bar, gradually decreasing the power to undercorrect the deviation until fusion is disrupted. Then you will go back and gradually overcorrect the deviation with the prism until fusion is disrupted. I think many people skip that second step, but it can be very valuable for the older patient who is going into strabismus surgery. We would like to know if we leave them with a slight overcorrection, which in many cases is recommended, how bothered will they be by postoperative diplopia? Now, there is an important exception to this method. If your patient has monofixation or ARC with a manifest strabismus, you cannot offset the deviation and then check the amplitudes. Adding the prism will simply stimulate their fusional reserves, and you will get a false response. If you're using fusional vergence testing to quantify control, The direction of the base of the prism should increase the vergence demand. So for an esotropia, we would want base in. For an exotropia, base out. In this case, if the deviation is intermittent, you can start with the lowest power of prism and increase until fusion is disrupted. You can then reduce the prism power until vision is restored to determine the recovery point. When is fusion restored? For intermittent deviations, using this method to quantify control, the recovery point is every bit as important as the break point. If the recovery point is very distant from the break point, that is not a good sign for control and indicates that the patient is likely on the path to deterioration. Now, I've been talking about fusion break, and diplopia is one sign of a break in fusion. But I always like to back that up with physical evidence. So I will always be observing the patient's eyes through the prism to determine when they have broken fusion. I can recognize this because the full deviation will now become manifest. If we are performing the sensory tests in order from least to most dissociating, stereo tests come next. There are some important exceptions, such as the Frisbee test. That is a test where glasses are not needed, and that could be done at any time. It is not dissociating. But that's not the most common test of stereopsis that we use. I would say that if motor fusion is the type of binocular vision that's the most often overlooked, then stereo tests are the most overused and overemphasized component of binocular vision. Probably a controversial stance to take on stereopsis. Often, it's the only type of binocular vision that's being tested on the sensorimotor exam. It is the most complex type of binocular vision. It requires precise alignment, good image quality in both eyes, and an intact cortical substrate for disparity detection and processing. So if your patient demonstrates stereopsis postoperatively, that says a lot about the success of your procedure. But the presence of stereopsis, as we typically measure it in the clinic, does not predict or guarantee long-term alignment, and in some cases may not even make a noticeable functional difference in the patient's day-to-day life. You can't miss what you never had. Stereopsis may be the least important type of binocular vision for those with childhood onset strabismus in terms of making a difference in their lives. Most of these patients learn to rely on monocular cues to depth. Now, there is a very important exception to this rule. Patients who had stereopsis and lost it due to the onset of strabismus, they will not be happy until stereopsis is restored. Having said that, testing stereopsis has tremendous value for the sensorimotor exam. It allows us to differentiate between central, meaning foveal fusion, and peripheral fusion. Gross stereopsis, 70 seconds of arc or worse, indicates only peripheral fusion. Fine stereopsis, 60 seconds of arc or better, indicates bifoveal fusion. So we can use this test to diagnose monofixation syndrome. We can also use it to monitor decompensation or loss of control in an intermittent deviation. It's important to recognize, though, that it is an indirect measure of decompensation because the decreased stereo that occurs as a sign of decompensation is due to a worsening of suppression. Abnormal stereopsis may be evidence of early childhood onset disruption of binocular vision, and that's important to know because it will temper our prognosis for the patient. Now, stereopsis testing may be skipped entirely in the presence of moderate to large angle constant strabismus or significant monocular or binocular vision loss. Important exception, the adults with suspected childhood onset exodeviations. We assume many of these cases began as an intermittent strabismus that allowed stereopsis to develop. They may be constant now with no stereo, but they had it before and might be able to get it again. For some reason, the polarizing stimulus has the effect of temporarily restoring eye alignment long enough to detect some stereopsis. Now we have to talk about the Titmus test because it is the most widely used stereo test worldwide and has been for more than 5 decades, in spite of its well-documented flaws, specifically the visible monocular cues to depth, but there are other issues with this test as well. It's easy to administer incorrectly, which will increase the likelihood of overestimation of stereo acuity. The testing distance is critical. It affects retinal image size, as does the interpupillary distance of the patient. Many clinicians are not aware that this test is calibrated for use at 40 centimeters, not 33 centimeters, where we normally measure near responses. It is very popular due to its availability, familiarity, ease of administration, but also because of the house fly. The fly test is valuable because the disparity is so large. 3,000 seconds of arc is much greater than most other commercial tests. So we tend to use that test to detect gross stereopsis in microtropic patients. The problem is that the flaws of the Titmus test are magnified on the fly. It's also difficult to administer the test without using leading questions that will tip the patient off as to the correct answer. And the answer tends to be a yes or no response, which means they have a 50% chance of guessing correctly. It's easy to memorize the correct answer due to overexposure, and this leads to an unacceptably high false positive rate. I think the Titmus test is the most reliable the very first time the patient sees it, particularly if the examiner does not prepare the patient for what they are about to see. In this way, you can get a spontaneous reaction that you can trust. Now, there are ways to use this test to reduce the false positive rate. One would be to administer the test using glasses with polarizers of matching orientation. The problem is that these glasses don't exist. They are not manufactured, so you would have to create them. What I use instead is repeating this test after rotating the book 90 degrees and comparing the responses. The Titmus glasses and the test book are constructed with orthogonally polarized filters to create the illusion of depth. The right eye only sees the image on the left half of the page. The left eye sees the right image. This crossed retinal image disparity creates the illusion that the fly is closer to the observer than the plane of the book. If the book is rotated 90 degrees, however, vertical image disparity is created. Now, the human brain can naturally detect vertical disparity, but it is unable to process it in a way that results in meaningful depth perception or any other visual quality. Bifoveal patients with true stereoscopic ability should report that the fly is flatter or maybe double or both. Patients with manifest strabismus who do not actually have stereopsis may report a single flat image due to suppression. But no patient should record an illusion of depth due to the change in orientation of the book. I think it's important to present the fly in both orientations, especially if this is the only stereo test I'm doing, and I'm going to compare their responses. For those with a history of years of follow-up exam, I start with the book in this orientation, ask them what they see, and then I rotate the book back to the orientation which it was intended to be used. After stereopsis, we finally come to sensory fusion testing. This comes last in our binocular vision series because these tests tend to be among the most dissociating. With this step, we not only detect sensory fusion, but we reveal information on suppression and retinal correspondence. Sensory fusion testing can yield information on foveal versus peripheral fusion, suppression, and retinal correspondence. You can glean a lot of information from one simple test here. Sensory fusion absolutely must be evaluated in all those patients with poor fusion, the ones who did not have motor fusion and did not have stereopsis, regardless of their angle size. You also must take this step for any patient reporting diplopia, and I would recommend doing it on all your preoperative patients. Now, it may be skipped in patients who already demonstrated motor fusion and fine stereopsis. But do not skip this step in patients with sensory strabismus. You may think there is no way that this patient is actually binocular. And you might be wrong. Some of the worst cases of postoperative diplopia that I've had to manage are in those patients with sensory strabismus where this step was not taken prior to surgery. Sensory fusion is the cortical process of integrating visual input from two distinct sources to construct a single image. Paradoxically, sensory fusion tests often use completely unfusible stimuli. Dissimilar images are being presented to the two eyes, and we are looking for evidence of fusion. There are some important caveats. Absence of diplopia in a patient who has strabismus does not mean that the patient has fusion or fusion potential. Presence of a manifest strabismus is not necessarily incompatible with fusion, and not all those patients with diplopia are capable of fusion. Although it's not common, some patients are just incapable of fusion, and it's important to identify them before the eyes are realigned. Diplopia with an inability to fuse can be congenital if the natural suppression mechanism has been lost, or acquired, usually due to brain injury. The value of sensory testing may be obvious, but why should we investigate suppression and retinal correspondence? There are several good reasons. Their presence will provide information on the age of onset and or the duration of the strabismus, and this can be important when determining the long-term prognosis. Next, the location and size of a suppression scotoma reveals the type and size of strabismus that was present during childhood. Third, it reveals the sensory angle, in other words, the eye position that is preferred by the brain for fusion. Hopefully, that position is with both foveas projected onto the fixation target, but that's not always the case. Number 4, it's used in the assessment of prognosis for single vision or fusion. And number 5, it helps determine the risk of postoperative drift and long-term outcome. Both deep suppression and anomalous correspondence can be associated with long-term poor surgical outcome. Testing sensory fusion is a two-step process at minimum. This is because we must evaluate both foveal and peripheral fusion. This information, these inputs are being processed in two distinct parallel pathways, all the way through to the entry level of the visual cortex and beyond. So it is possible to have a fusion response under one condition and a suppression or diplopia response in another. In fact, almost any combination of responses is possible, except you cannot have foveal fusion with peripheral suppression. When performing these tests, the angle subtended by the retinal image is critical. When we want to test foveal fusion, the retinal image size must be no greater than 1.5 degrees. If we want to look at peripheral fusion, we want a larger target, but not so large as to fall on the monocular crescent of either eye. So about 6 degrees is ideal. The test results are going to be recorded as one of the 3 responses: fusion, which again is not really fusion, it's more simultaneous perception; diplopia, or suppression. We record 2 responses, one for the foveal targets and one for the peripheral. Keep in mind that the response to these tests, is this fusion or not, cannot be interpreted correctly unless alignment is known. Now, one of the most popular tests for sensory fusion is the prism offset of the tropia. This is going to be sufficient for those with acquired strabismus and diplopia, particularly in the case of moderate to small angle strabismus. It gets a little more difficult with larger angles because the prism that you must use does distort and blur the patient's vision. There are many advantages to this test. It's quick and easy. No special equipment or power source is needed. It's portable. But most importantly, it allows a real-world fusion-friendly viewing. It is very simple for the patient to understand and for the examiner to perform. But there are some disadvantages. This type of test does not differentiate between fusion and the simple absence of diplopia. Sometimes we need to know if that fovea is being suppressed. It's not helpful in those cases who also have a cyclotropia associated with their strabismus. It may not be accurate for those whose deviations fall in between the prism strengths. Large prisms can mask diplopia and fusion and may give misleading results. And it's not accurate for those with a history of anomalous binocular vision. I'm going to speak a little bit now about the Worth 4-dot test because, like the Titmus test, this has been around for generations of clinicians, is commonly available, and most people use it frequently. There are advantages to the Worth 4-dot test. It is quick and easy. It is portable. It's easy for the patient to understand what is required of them. It can be used to test both central and peripheral fusion simply by altering your testing distance. And it differentiates between fusion and absence of diplopia. It also can be modified to evaluate the size and depth of the suppression scotoma and can be used to evaluate anomalous correspondence. Disadvantages. This test is not fusion friendly. Again, many sensory fusion tests are not. But let me take this opportunity to explain what I mean by fusion friendly. These are comfortably lit surroundings with contours in the peripheral field to provide fusion cues. This is going to be a visual environment that not only encourages fusion, but also will encourage suppression if the patient has suppression. Only those patients with deeply rooted, robust binocular vision, whether normal or abnormal, will demonstrate a fusion response on such a highly dissociative test. It is easy to learn the correct answer. Perhaps not as easy as with the Titmus housefly, but still pretty easy. The anaglyphic format on which this is based may result in false responses in those with uncorrected refractive error. And the test isn't standardized from manufacturer to manufacturer. There may be discrepancies in the luminance and contrast between the red and green filter that could give you incorrect results. When I do the Worth 4-dot, I do it the following way. I start with the room lights on, at distance with the flashlight. This ensures that I'm going to be projecting the stimulus onto the fovea. I simply ask the patient, how many lights do you see? And if they say 2 or 3, I would indicate that as a suppression response. If they tell me 4 lights, that is recorded as fusion, though it is more like simultaneous perception. And 5 lights could mean diplopia or alternate suppression. If your patient gives you the response of 5 lights at distance, it is important to ask a few more questions. Are all 5 lights present at the same time, or are they alternating between 2 red and 3 green? Next is an optional step. If I want to use this test to get an idea of how large the suppression scotoma is, I'm going to walk slowly towards the patient with the flashlight illuminated and ask the patient to tell me when the number of lights changes. I will at some point reach a boundary where they now see 4 lights, or I will be able to go all the way up to 1/3 of a meter with the patient continuing to report 2 or 3. If you then measure the distance between you and the patient when they first saw 4 lights and measure the size of the stimulus on the flashlight, you can plug those numbers into a simple mathematical formula and actually calculate the size in degrees of the retinal suppression scotoma. The next step is not optional. We're going to repeat the testing at near 1/3 of a meter. You have to do both because the answers may be different. At this point now, we have another optional step. I might turn the room lights off. This is going to make the test more dissociating, so I can get an idea, a qualitative assessment of how deep that suppression is. And the final optional step is to offset the deviation with prism, thereby projecting the Worth 4 dot target onto the deviating fovea to assess the visual direction of the fovea under binocular conditions. And I can do this with the room lights on or off. That is a test for retinal correspondence. And so let's just take a minute to talk about what correspondence is. Input from the 2 eyes must correspond in the visual cortex because we have frontally placed eyes with extensively overlapping visual fields. Retinal elements, which by that I mean the neural apparatus from the rods and cones all the way through to the layers of the cortex, are likely pre-tuned to correspond normally. But that correspondence has to be reinforced by normal binocular experience in infancy. By recognizing which points correspond, the brain becomes aware of the points that don't correspond. And we need that to localize objects in space under binocular conditions and for Vergence eye movements. Anomalous retinal correspondence is the adaptation to misaligned visual axes in which the subjective visual direction of the non-fixating eye is shifted relative to those of the fixing eye, but only under binocular conditions. The purpose is to allow for some crude binocular vision. That binocular vision may simply be sensory fusion, peripheral sensory fusion. It might also be fusional vergence. Probably not stereopsis, but if stereopsis is present, it's going to be very gross. Almost any test for binocular vision can be used to glean information about correspondence, although certainly there are specific tests that have been designed to evaluate retinal correspondence. In my opinion, it is easiest to detect abnormal correspondence using a sensory fusion test rather than motor fusion or stereopsis. A fusion response in the presence of a manifest deviation is evidence of anomalous correspondence. Binocular diplopia response in the presence of orthotropia may also be evidence of anomalous correspondence. Like suppression, abnormal binocular correspondence is sensitive to testing format and the visual environment. The further removed you are from fusion friendly, the more profound the anomalous correspondence if the patient is still reporting fusion. In general, the deviation point, the point on the deviating eye that is receiving the image straight ahead, is easier for the cortex to rewire, to correspond to the fovea of the fixing eye than it is to rewire the fovea. Those patients who report binocular diplopia when both foveas are receiving the same image have a much more deep-seated ARC and are at increased risk for temporary paradoxical diplopia post-operatively. For example, when I mentioned offsetting the deviation with prism and repeating the Worth 4 dot. Testing for retinal correspondence can be skipped in patients who have fine stereopsis. If your patient has 60 arc seconds of stereo or better, you don't need to do this step because, by definition, they have bifoveal fusion. You can also skip this step on a patient who reports a fusion response with distance testing of the Worth 4 dot. In other words, the stimulus will be falling on both foveas. You have to test retinal correspondence on any patient with childhood onset long-standing grossly comitant strabismus. Those are the ideal circumstances in which anomalous correspondence develops. It is particularly important to determine the visual motor direction of the deviating fovea under binocular conditions due to that elevated risk of postoperative paradoxical diplopia. Fovea-to-fovea tests, like the Worth-4 dot with prism offset of the deviation, stimulate both foveas simultaneously with similar images under binocular conditions. Now we are finally ready to return to our motor exam. Here we're going to look at the eye alignment in our secondary and possibly tertiary gaze positions, versions, inductions, and other testing as needed. The purpose of version evaluation is to evaluate the primary function of each of the 6 extraocular muscles in each eye. We do this by comparing its function to the contralateral synergist or yoke muscle. Presence of limitations or so-called overactions may inform your diagnosis and certainly may help you in your selection of surgical procedure. To do this, we rotate the globe into the field of action of each muscle. The field of action is the gaze position that isolates the function of that particular muscle. To observe the field of action, the globe is rotated so that the plane of the muscle is parallel to the line of sight. In this position, when the muscle contracts, you will observe its primary function. If a limitation is noted, we then immediately check ductions to see if the rotation can be more complete in that circumstance. Most examiners will have a patient pursue a target into the field of gaze of each of the 6 extraocular muscles, as you see here. Some will prefer to bring the patient back to primary position, to fixate here again, before going into the next gaze position. Others may have the patient make a large saccade from primary into each position. And still others may use the doll's head maneuver, or the VOR, to rotate the eyes. In most cases, though, the method is less important than the endpoint. It is important to get the eyes fully into the desired gaze in order to make the correct evaluation. Abnormalities on versions are usually graded on a -4 to +4 scale, with 0 indicating normal function. It is a highly subjective grading system. There really isn't a good way to standardize this test, and it's highly dependent on the examiner's own experience. Because overaction does not really exist physiologically, the appearance of oblique overaction may be the result of unopposed action, such as in the case of a paretic ipsilateral antagonist. Otherwise, we're really using the term overaction to describe what it is that we are seeing. It's easy to be deceived by eyelid position, lid fissure slant, epicanthal folds, exophthalmos or enophthalmos, or orbital asymmetry. So move the lids out of the way, even the lower lid. Look at the position of the limbus relative to the limbus of the other eye. This is particularly important for evaluation of superior oblique function. Personally, I find this muscle the most difficult one to evaluate on versions. Quantifying the deviation in different gaze positions is essential to detect incompetence and the field of greatest deviation, which is going to assist in your diagnosis. But this also plays a role in identifying the involved muscle. The cardinal positions of gaze, which are circled here, are those gaze positions that isolate the function of individual extraocular muscles. So they include 2 of the secondary positions and all 4 tertiary positions. We don't necessarily have to measure all of those gazes in every patient. I will come back to that in just a moment. The standard testing distance in my office is to measure at distance when we are measuring in gaze positions. But either testing distance will reveal a pattern of misalignment. Personally, I find it easier to use distance fixation because of its repeatability. It is easier for me to position the eyes correctly from visit to visit when I measure at a distance. Positioning the stimulus is important. Usually if we're measuring at distance, the stimulus is stationary. What changes is the head position of the patient. I rotate the head to the limit of neck flexibility. Then I will check to see if the patient is able to see that fixation target with each eye individually. If not, I will rotate the chin back slightly until they are able to see the target with either eye. If I'm measuring in an oblique position of gaze, I use a two-step method to get there. For example, chin down and head rotation this way. This gets me in the same position at every visit in my room. Which gazes should be examined? It depends. If the deviation is horizontal, at minimum, you need up and down gaze to look for a pattern, especially if your patient is a child or had a history of childhood onset strabismus. If it's vertical, at minimum, you want to check right and left gaze as well as right and left head tilt. But there are many situations where you may need to measure the patient in an oblique gaze position. At this stage, we are looking for patterns of incompetence and primary-secondary deviations that will inform our differential diagnosis. For this reason, we will place the prism over the involved eye, whether it is the preferred eye or not. It is very easy to rotate the prism out of correct position in the secondary and tertiary gaze positions. Small rotations out of the frontal plane can happen even in primary, but side gazes are even more difficult to maintain that frontal plane. Prism rotation can mask or create incompetence or a multiplanar deviation that isn't really there. We don't want to inadvertently create incompetence. It's very easy to obstruct the patient's view when measuring moderate to large deviations in right and left gaze if you use the same method that I recommend to get the patient in the correct gaze position. In extremes of gaze, globe rotation is going to be limited by soft tissue in the orbit, such as the muscle pulleys. We also want to minimize false incompetence in large deviations by placing the prism over the eye with the least freedom of rotation, since that eye cannot move fully because of the gaze position. We can use the prism on that side to avoid that issue and watch for movement in the fellow eye. So in other words, we're going to use base out prism over the abducted eye, if we're measuring an esotropia and side gaze, and base in prism over the adducted eye, if we're measuring side gazes in an exodeviation. There are several special tests that are not used on every patient. They are used as needed. These are some of the most common ones. Prism adaptation, where we can double check our measurements to make sure that we got all of the deviation measured, but also can give us some idea of fusion potential. Typically, for me, I use this in horizontal strabismus with a distance near disparity, but I don't often use it in everyday strabismus. Diagnostic occlusion is very valuable. Any child or adult with a history of childhood onset strabismus can benefit from diagnostic occlusion, even if they appear to have a constant tropia. The diagnostic occlusion can also be used in a patient with a head posture for unknown reason, and once again, to double check your measurements by bringing out the full deviation. Calculation of the ACA ratio may be valuable, again, in any patient with a childhood onset horizontal strabismus, even if that patient is an adult. And of course, cyclotropia. All patients with any type of vertical, with the possible exception of a dissociative vertical deviation, should have an evaluation for cyclotropia. But in addition, any patient who was unable to fuse with prism offset, or under any other circumstance, that patient needs evaluation to determine if there is a cyclotropia. Now, this is not an exhaustive list of special testing. There's far distance measurements out a window, ultra near measurements, a synoptophore exam for complex diplopia and fusion abnormalities, evaluations of saccades, smooth pursuit, and vestibular eye movements. These are all examples of tests that I use every week, but not on every patient. These four are probably the most commonly added additional tests. Now we have completed our sensorimotor exam. The next step is going to be to evaluate pupils, because many of the diseases, disorders, and injuries that cause strabismus may also affect pupil function. And we're also going to end with an evaluation of the refractive error. No comprehensive workup would be complete without it. Now, this is going to include lensometry to look for hidden prism in the glasses. It is always surprising to me when I discover prism in the glasses and the patient has no knowledge that the prism was put in there. We also want to look to make sure that the refraction is accurate for a couple of good reasons. An accurate refraction is needed to clear the retinal image. This will improve the patient's fixation, which means it's going to improve the accuracy of your measurements. We also want to maintain or restore the best vision to the dominant eye. We need a good refraction to control and balance accommodative effort as well. The value of a good cycloplegic retinoscopy cannot be overstated, particularly for the adult patient. Just because your patient is presbyopic or pre-presbyopic doesn't mean accommodation isn't affecting eye alignment. It is accommodative effort, not the response, that determines the amount of innervation that is simultaneously going to the medial rectus muscles. So a cycloplegic refraction can be critical in the adult patient. To conclude, the path to diagnosis and successful management is not usually a straight line. An accurate and complete diagnosis can be made using very common and simple tests if your technique is sound. Binocular vision testing is just as important as good motility exams preoperatively. And binocular vision can inform the choice of management, but also may influence the patient satisfaction and long-term outcome. I want to thank Dr. Kushner and One World, One Vision for inviting me to participate in this comprehensive course on strabismus.
Well, thank you so much, Professor Arnoldi. That was concise, complete, and totally clear and full of very valuable pearls. I do have just two short questions, if I may. You said that when doing the induced tropia test with a vertical prism, kind of the Goldilocks phenomenon, you don't want one too big or too small. What specific size prism do you use?
I typically use a 10 prism diopter prism. When I am teaching my students, I will have them use a 14, 15 prism diopter prism initially because it will be easier for them to see. But nothing less than 10 and nothing more than 12 for me.
Okay, thank you. That's helpful. The other question I have is, do you have any pearls on how to handle a patient that shows redress when you're measuring them? Some patients, you can get a nice end point with the prism and alternate cover test, and some, they still move and move back, and you have to estimate, is the in movement the same as the out, or so on. Anything can help in that situation?
I'm glad you brought that up. I find this happens most often in patients who have had a childhood onset strabismus. Now, they may still be children or they may be adults, but they have a long history of a misalignment. This, of course, is very difficult to find the appropriate endpoint. There are occasions when I will do my prism and alternate cover test and then go back and double check with a corneal light reflex test. By the way, when I use the corneal light reflex test, I also measure to reversal. So I keep adding prisms until I see that I've overcorrected the patient. But to be honest, most of the time, it is my own experience and watching how much the eye is moving in one direction and how much back. That is what I use to determine the endpoint. Occasionally, I record a range as opposed to a specific number, but that range is narrow, typically within 5 prism diopters. Those are challenging cases. Some of them do this because they have decreased vision in one eye or visual field loss. And so prolonging the alternate cover test, really giving them time to fixate with the eye that I just uncovered can be helpful in this case. But not always. It really is no substitute for clinical experience in this.
Thank you. That's very clear and helpful. And with that, I will say this concludes the One World, One Vision Comprehensive Strabismus course lecture on the sensorimotor exam.
In bringing you this video course, there are many thank yous. Thank you for viewing the video course on strabismus. We hope you found it stimulating and educational, and that you share its insight with others. We at One World, One Vision extend our heartfelt thanks to the lecturers who shared their years of study to make the video course worthwhile. And of course, to Burt Kushner for taking on the burden, happily we hope, of development and moderating. We also thank the Board of Directors for their continued guidance. We thank our donors for their financial support that made this video course possible. An enormous thank you to the video team of Sweet Sadie for their extraordinary efforts to make the course both visually and auditorially extraordinary, and for their technical guidance of lecturers. Thank you, Rachel, Tim, Eddie, and Bill. If you are interested in learning more about what we do, go to our website, www.oneworldonevision.org. And finally, if you have comments or thoughts or ideas, you can email me at owov2020@gmail.com. Goodbye.